So I'm Faysal Yafi. I'm the Director of Men's Health and an Associate Professor and Vice Chair of Urology at the University of California, Irvine. I've been in practice now for coming up on 9 years, and my practice includes all aspects of men's health, including sexual dysfunction, low testosterone, Peyronie's disease, and BPH. We now have so many options for BPH. Historically, the conversation used to be very short. Now we have a lot of options to go over with patients. And again, when we're talking with the patients, we have to look at what are their goals of care. Are they looking for improvement in their urination alone, or are they really important for them to preserve their ejaculation as well? So these are important conversations that we have with the patient, and this is also why there's been a rise in what we call missed procedures, and Optilume is certainly one of those options. I think the optimal patient for Optilume BPH is a patient with a prostate size probably less than 90 cc's, without a very large median lobe, and who is really interested in preserving their ejaculation. So a lot of the patients who are coming in today to see us, one of their main goals are they want to improve their urination, but they want to be able to preserve their ejaculation. So obviously the procedures where you're going to be resecting are going to probably improve urination sometimes better, but they will have deleterious effects on ejaculation. So we spend a lot of time discussing the goals of their care, and if they're interested in preserving ejaculation, I tell them that with Optilume, at least from the studies that we've had from the Pinnacle and the Everest, and from our personal experience, the ejaculatory function is preserved for the most part. There are 2% of patients who may notice some changes in their ejaculation, but we haven't seen any patients who have not been able to ejaculate after Optilume BPH in our practice. When we talk about flow rate after any procedure for BPH, there's an immediate, post-op period where after the catheter comes out, where the patient may still have some inflammation, some swelling, they're still recovering, the bladder is still recovering, that we tell them that, to be a little bit patient. We usually start assessing the urinary improvements at 2 weeks, and then at a month, and then 3 and 6 months. But we usually start noticing patients telling us that, yeah, the flow has improved at the 2-week mark when we see them the first time. Yeah, so when we're talking about expectations, and improvement of flow, what I tell patients is kind of what mirrors the Pinnacle trial. I tell them that they should expect around 55 to 60% improvement in their flow rate. They should expect a decrease in their residuals, and that they should expect that the quality of life is going to be improved afterwards. And also, hopefully, if they were on medications, we tell them that in all likelihood, we're going to be able to get them off their medications if everything goes well. Hematuria is a concern after every BPH procedure. Obviously, procedures where we have heat and where we're, taking care of the bleeding at the time of the procedure, you're going to have potentially less bleeding afterwards. With Optilume, you're stretching the prostate and you're kind of causing a tear to a certain extent, so bleeding is expected. So in the immediate post-op, they're going to have a catheter. We're going to irrigate the catheter. We tell them to expect bleeding within the catheter and around the catheter in those first 2 days when they have a catheter. But what I tell patients is in the first 2 weeks after the procedure that they can expect some bleeding per urethra and some hematuria. We usually recommend that they put a liner in their underwear to kind of catch some of that blood. But after 2 weeks, the expectation is that the bleeding will subside to almost to a stop. Some patients will have some continuous bleeding afterwards, especially if they're on blood thinners after the procedure. But for the most part, we tell them to expect the bleeding mostly in the first 2 weeks after the procedure. So we do the Optilume procedures in the surgery center under MAC anesthesia, and we give the patients relaxants so that they're comfortable. It could potentially be done in the clinic under local anesthesia as well. It hasn't been our experience yet, and the reason is I think it's really important to be able to set the balloon and take your time and not be concerned about the patient fighting you while you're doing the procedure. With regards to the blood thinners, we usually tell the patients to stop the blood thinners depending on what thinners they're taking at the period that is requested before the procedure, and we usually tell them they can restart 3 days after. Obviously, this is with consultation with their internist or their primary care physician. In terms of other things that we do give all the patients antispasmodics as they're going home, because they will have bladder spasms with the catheter in place for the 2 days after the procedure. In terms of pain control, for the most part, all we give is Tylenol after the procedure. We have given narcotics to a couple of patients who may have a lower pain threshold, but for the most part, we've been fine with just Tylenol for those patients. So I think Optilume BPH is a great option. I think for patients with mild to moderate enlargement of their prostate, Optilume BPH offers results that are probably superior to what we see with the standard MIST procedures that we have out there, and probably closer to what we see with some resecting procedures like TURP. So again, going back to what the Pinnacle trial showed, usually we tell patients you're going to expect about 55 to 60% improvement in your urination and the flow, and decrease in your residuals. For the most part, we've had really good outcomes with our patients. But again, like any other procedure, the most important thing is patient selection. If you pick the right patient, you're going to have the best outcomes. And if you discuss with the patient at length prior to the procedure the expectations, I think you're going to have happier patients. But it's a really good procedure, and it's a really good addition to our arsenal for the management of BPH. I think the arsenal of options that we have for BPH keeps on increasing, and we have more and more options. Some of the options that we used to use in the past, standard on everybody like a TURP, are kind of decreasing. I think here, for example, at UCI, our management protocols have changed since Optilume came into the market. We like it as our go-to option in our mild to moderately large prostates. For the very large prostates, obviously it's not gonna do well, but I think it's something that every urologist should be trained on and should consider it as an option for patients with BPH. And we're having more and more patients coming in through our door asking for Optilume BPH today, because they're hearing about outcomes, they're reading about it in forums, they want to preserve their ejaculation without giving up on improvement in flow. So I think it's a great balance between improving flow and preserving ejaculation. So I think its place is really important in the armamentarium that we have for BPH management.